Hi, and thank you for joining me. As you can tell from the title of this talk, we're going to be talking about risk, resilience, ACEs, which are adverse childhood experience, and social determinants of health. Basically, we're going to be looking at all those environmental factors that impact a child's development. So our theme today is how to help all children in your practice or your classroom thrive. We'll discuss these concepts of risk and resilience, review biologic responses to chronic stress, review a study called the ACE study for adverse childhood experiences, discuss screening for these adverse childhood experiences, as well as another term we'll discuss, social determinants of health, and then talk about interventions that help and provide some resources. What we would like for our children is a caring caregiver adult, secure attachment, strong support network, stimulating environment, access to high quality childcare, and access to quality early interventions in schools. For example, we would like an adult who responds to children's emotional and physical needs with warmth and reassurance, encourages children to talk about and label feelings, models problem solving and conflict resolution, practices solutions and anticipating consequences, teaches children stress reduction techniques, helps children practice listening and talking, teaches children to verbalize rather than act on feelings, teaches children to help others and understand and appreciate similarities and differences between people, models respectful behavior towards the child. In short, we'd like an adult who prepares the child to participate in productive activities, develop fulfilling relationships with other people, and be able to adapt to change and cope with adversity. Unfortunately, many children are living in stressful environments. Children of alcoholics or drug addicts, children in families whose parents have mental health disorders, children in families with disabilities and chronic illness, children who've been neglected and abused, children of divorced parents or absent parents, foster children, children of immigrants or bicultural families, children who have experienced specific disasters or who are homeless. These are all what we would call risk factors. So some comments on terminology. Again, from a child and developmental perspective, risk is the probability that a child will experience an adverse health outcome, especially in the context of exposure to a specific situation or event. So risk factors are conditions or variables that increase the likelihood of negative outcomes for children. And when we talk about risk, we talk about different types of risk. There's biologic risks, for example, prematurity, low birth weight, interuterine growth retardation, failure to thrive, things I think you've just heard about. We're going to be talking today about social risk, which really is environmental risk. And again, it's also referred to as adverse childhood experiences. For example, poverty, single parenthood, low parental educational levels, exposure to domestic violence. Another term is established risk, and those are children who have a definite disorder, a developmental disorder, likely a chromosomal disorder, sensory neural hearing loss, something like that. But more importantly, we're going to be talking about cumulative risk. This is really a combination of risk factors, particularly social risk factors, that has a much greater impact on the child's development than just one risk factor alone. More on terminology. A very important concept, in addition to risk, is resilience. This quite simply is the ability of the child to adapt to and thrive despite these risk factors, despite challenges and hardships. We talk about protective factors. So these are conditions that promote the child's development and social emotional growth. For example, with older kids, this might be high self-esteem, high self-regulation, high academic abilities. For the family, these protective factors might be a positive parent-child relationship, positive and consistent parenting, high family cohesion, a trustworthy adult. What we'd really like is to balance that teeter-totter with the positive outcomes or positive protective factors far outweighing any adverse experiences or risk factors. And to learn more about the concept of resilience, there's a wonderful series of videos developed by the Developing Child Center at Harvard University here in the United States. And I'm quoting from some of their material. Reducing the effects of significant adversity on young children. Children's healthy development is critical to the progress and prosperity of any society. A better understanding of why some children do well despite early adversity is important because it can help us design policies and programs that help more children reach their full potential. And again, these 3 videos provide an overview of why resilience matters, how it develops, and how to strengthen it in children. And there's the resource. Another way of looking at it is who is at risk. We traditionally focus on the child, but others argue that it's not just the child that we need to think of. We need to think about the family as well as the community and society as a whole. So the family at risk would be, again, that family with poverty or single parenthood. Community at risk may be a low-income community where there's a high crime rate, higher water and air pollution. This concept leads us to thinking about social determinants of health, where we need to think about impact at not just the child, but at the family, as well as the community and society levels. And again, terminology. So social determinants of health are those non-medical factors that influence health outcomes. There are conditions in which people are born, grow, work, live, and age, systems shaping the conditions of daily life. This includes economic policies, social norms, social policies, racism, climate change, and political systems. And this is taken from the World Health Organization. So here's some examples of social determinants of health. On the positive side, safe housing, transportation in neighborhoods. On the negative side, presence of racism, discrimination, and violence. On the positive side, access to education, job opportunities, and a living wage, access to nutrition, foods, and physical activity. On the negative side, exposure to polluted air and water. Again, on the positive side, language and literary skills in the child and family. So we're going to look more on, background is now on the science of chronic stress. So I think we all are familiar with the concept of the flight or fight response when we're exposed to a frightening or stressful event. This causes changes in hormonal and sympathetic activity in the body in preparation for how we respond. It causes this release of this hormone, the corticotropin-releasing hormone, which is in the hypothalamus. It stimulates the pituitary gland to secrete another hormone called ACTH, or adrenocorticotropic hormone. That hormone is released by the pituitary gland in response to the CRH. It stimulates the adrenal cortex to produce glucocorticoids, or cortisol, which increase blood glucose, blood pressure, and help us prepare to respond to that stress. Acute stress also results in a release of epinephrine and norepinephrine from the adrenal medulla. Epinephrine causes, again, increased heart rate, respiration, increased glucose metabolism, and norepinephrine will increase blood flow to muscles and increase blood pressure. All of these are important as they make us get us prepared to respond with that flight or fright response. And this is a schematic of how it works, what we call the hypothalamic pituitary adrenal axis. You see the arrows coming from the hypothalamus, where the CRH is released, to the anterior pituitary, where ACTH is released, which acts on the adrenal, which releases corticosteroids. And you see the same pathway where sympathetic nervous system activates the adrenal gland, the medulla, to release the epinephrine and norepinephrine. And this is another schematic that looks at stress, but this time chronic stress, or what we might be called toxic stress. So what happens when there's chronic activation of the the physiologic flight or fight response, this HPA axis. So this toxic stress results in the chronic activation and chronic increase in cholesterol can actually change brain architecture and leads to a hyper-responsive stress response over time. Now we're going to pay our attention to that study I mentioned earlier, the Adverse Childhood Experiences Study. This was conducted through a healthcare system in the United States, Kaiser, with support from our Centers of Disease Control. And they followed well over 17,000 patients, and they had them complete the surveys, and they get a 70% completion rate, which is actually very good. And it really looked at 7 categories of adverse childhood experience: physiological, physical, or sexual abuse, violence against the mother, living with household members who have substance users, mentally ill or suicidal, or parents who have ever been imprisoned. And this was compared to measures of adult risk behavior, health status, and disease. And the key findings of that study are that more than 1 in 4 respondents grew up in a family with substance abuse. 2/3 had at least one adverse childhood experience. 1/4 reported 2 or more categories of childhood exposures. And 1 in 6 reported 4 or more adverse childhood experiences. And when we looked at outcomes, these ACEs were greatly increased the risk for adult alcohol abuse or marriage to an alcoholic. Persons who had experienced 4 or more categories as children, compared to those who experienced none, had 4 to 12-fold increased health risk. For example, to alcoholism, drug abuse, depression, and suicide. Graded relationship to the presence of adult diseases. So the more ACEs, the more likelihood the adult diseases, including ischemic heart disease, cancer, chronic lung disease, skeletal fractures, and liver disease. So the conclusion of this study was they found a strong graded relationship between the breadth of exposure to abuse or household dysfunction during childhood and multiple risk factors, and for several of the leading causes of death in adults. So subsequent research on these adverse childhood experiences has expanded the number of potential adverse health and related outcomes. And as you can see from the slide, for physical and mental health outcomes, including type 2 diabetes, obesity, heart disease, depression, anxiety, addiction, cancers, obstructive lung disease, liver disease, higher rates of school dropout, divorce, and unemployment. So clearly, this, in terms of supporting children and helping them be the most successful, we have to address these types of factors. So the idea of screening for these in a primary care, healthcare setting has become center stage. It's been adopted by the American Academy of Pediatrics, and it's also consensus at an international level. So research and practice has shifted from delineating the effects of ACEs to how do we prevent ACEs in children? Or how do we support them once they've been exposed to these adverse childhood experiences? So screening in pediatric medical settings or primary care settings clearly presents an opportunity for early detection and then intervention and treatment. So there's more background on screening for ACEs. So here we have the 2016 National Survey of Children's Health, and it looked at these adverse childhood experiences, and almost 1/3 of children had one. Excuse me, almost a half of children had been exposed to at least one adverse childhood experience. Almost 1/3 of older children had 2 or more ACEs. And all of this information related to American Academy of Pediatric policy statements and recommendations to, yes, we should be screening for toxic stress and social risk factors and providing provision of, providing appropriate trauma-informed anticipatory guidance and positive parenting and advice, and advocating at a societal level and community level as necessary. So what are the barriers really to screening for ACEs in a primary care practice? Well, it's a lack of knowledge of available tools, concerns about the time and feasibility of integrating these assessments into practice, lack of confidence or skills in managing these conversations, a perception of a parent or patient who might be that they might be resistant to being asked these kinds of questions, concerns that the pediatrician would then be put in the position of needing to do mandatory reporting of potential child neglect, something similar. And again, lack of proven interventions once trauma has been disclosed or identified. So on the other hand, when thinking about the benefits of screening, so the goals of universal screening of parents or caregivers are generally not to force a disclosure, but to open a conversation about toxic stress as a way to offer education and referrals to necessary services. And I'm taking this from a colleague and friend who's a pediatrician in Portland, Oregon in the United States. He goes on to say, when screening for ACEs, particularly follow-up questions when you've asked all the questions about these experiences. So follow-up questions such as, do any of these experiences still bother you now? Of those experiences that no longer bother you, how did you get to the point that they didn't bother you? And thirdly, how do you think these experiences affect your parenting now? And Dr. Gillespie's recommendation is that using these simple follow-up questions will help providers identify further needs and keep the conversation at a more manageable level. And again, more from Dr. Gillespie. When asked about needed or desired resources, parents identified parenting resources and support as their primary need. And information was the second most common self-identified need. So this information really mirrors the AAP's policy statement, which suggests that positive parenting resources and enhanced developmental promotion are desired outcomes of this type of screening. So next, I'm going to show you an example of one ACE screen, and there are several ACE screens available. This was is available at the Center for the Developing Child at Harvard University again, and it involves 10 questions. And this slide shows the first 4 questions, and if you will, each category has more than one question. So before your 18th birthday, did a parent or an adult in your household often or very often, again, swear at you, insult you, put you down, or humiliate you, act in a way that made you afraid that you might be physically hurt? Next question asks similarly about more physical kinds of abuse. Next question asks more about sexual questions, ask more about sexual abuse. And the last question on this slide is more about how often did you as a person feel that no one in your family loved you or thought you were unimportant or special, as well as other follow-up questions. These are the remainder of the 10 questions. And again, asking about access to food or potential food insecurity, asking about parents who may be too drunk or high to take care of you or provide for you the appropriate care. Ask about parents who are separated or divorced. And again, asking about mother or stepmother, how often they use physical discipline. However, did they experience physical discipline when they were growing up? And again, ask about being exposed to a gun or knife or threatened with a gun or knife. Live with anyone who was a problem drinker or alcoholic or used street drugs? Was a household member depressed or mentally ill? Was there a household member who attempted suicide? And again, the last one, which was part of the ACE study, did a household member go to prison? So this is one example of an ACE questionnaire that can be completed by parents and then used as the basis for an interview in the office. This type of approach was studied, and this study was published in Journal Pediatrics in 2023. It's called the We Care study. And they used a 12-question ACEs questionnaire, if you will. It had 6 domains: parental educational attainment, employment, childcare, risk and homelessness, food insecurity, household heat and electricity availability or lack thereof. And they had specific interventions. Intervention consisted of three core components: the We Care screening estimate, community resource information sheets made available to the parents, and a peer patient navigator. So they actually had a care coordinator or someone who could help parents find resources, follow up these surveys. And what they found in terms of results is that there were limited use. Families, only about 30% of families actually completed the surveys. And when they looked at outcomes in terms of change of behavior, there were mixed benefits on immunization, healthcare utilizations, and maltreatment outcomes. So they couldn't report any positive outcomes from this type of intervention. What this leads to is that clearly we need more research to decide some unanswered question. What's the best screening tool? What's the best way to implement it? And does really screening impact health outcomes? And so the bottom line is, and this is taken from a follow-up editorial in Pediatrics, the bottom line is that social determinants of health screening is complicated. And again, Dr. Krugman, I would encourage pediatricians to not give up on the practice, to make sure that, but to make sure that everyone is treating social determinants of health screening as a quality improvement project. This is, again, acknowledging that we have much to learn, and we're need to study these types of interventions. So this provides you some English language resources on screening for ACEs and social determinants of health. Dr. Krugman's editorial, the article by Dr. Gillespie, and a couple of other articles. So this slide presents some examples of evidence-based programs that will help prevent ACEs or provide secondary prevention and supports to children and families. So home visiting programs, so a nurse-family partnership. With one of these programs, 50% reduction in domestic violence, 50% reduction in reported abuse and neglect. So very important outcomes. So early Head Start and Head Start are other programs that are evidence-based programs preventing adverse childhood experience and providing ongoing supports to kids. Pre-K, again, building confidence and resilience in kids. And from one study, Head Start pre-K increases high school graduation, increases earnings at 27 years of age, and reduces crime. More examples of interventions to prevent ACEs, and this is really looking at social determinants of health. So interventions that address housing, strong evidence of benefits for housing first interventions that provide supportive housing to individuals with chronic health conditions. Food and nutrition, so efforts to improve food access through healthy food environments. Example, having healthy food available in all neighborhoods, not just well-to-do neighborhoods. Public benefit programs, healthcare systems, health insurers, and evidence-based nutrition standards all addresses the issues of food and nutrition. Transportation, so enhanced built environment interventions like sidewalks, bicycle infrastructure, places for people to walk, public transit infrastructure, where they can make access to where areas for increased physical activity, so they're easier to access them, safer. And then lastly, social and economic mobility. And multiple randomized trials show that cash payments to families and income support for low-income individuals with disabilities create many positive outcomes for these families, including increased employment in the future. And so again, a resource on these particular strategies is at the bottom of the page, and it's taken from our Centers for Disease Control. Also taken from the CDC website are these strategies and approaches. So this, again, you'll see that these address the child level, the family level, and the community or societal level. So strengthening economic supports for families, And ways to do that is strengthening household financial security by a monthly payment, family-friendly work policies, strategy, promote social norms that protect against violence and adversity. So approaches, public education campaigns, legislative approaches, reducing corporal punishment within families, uh, education of bystanders, how they can support families in certain situations, and using, again, enlisting men and boys as allies in prevention of violence. Another strategy, ensuring a strong start for children. Again, we get to the early childhood programs. These include early childhood home visitation, high quality childcare, and these preschool enrichment programs that get family engagement. Another strategy, teaching skills approaches. So focusing on social emotional learning, teaching safe dating and healthy relationship skill programs, teaching parenting skills and family relationship approaches. And continuing, so a strategy, connecting youth to caring adults and activities and approaches, mentoring programs, after school programs, one in the United States called the Boys and Girls Club. Strategy, intervene to lessen immediate and long-term harms. And so approaches, enhanced primary care, victim-centered services, treatment to lessen the harms of ACEs, treatment to prevent problem behavior and future involvement in violence, and family-centered treatment for substance abuse disorders. So some of the treatment may be teaching parenting behaviors. And there are a number of different parenting programs in use around the state. One called Triple Ps, another here locally called Parent-Child Interaction Training. This is for parents of young children. And here are a list of resources on adverse childhood experiences taken from the CDC. And you'll notice that my slides were taken from this website. And we're going to look at kind of the opposite. Here's a study that looked at 17,000 adults, and they compared positive experiences to outcomes. So comparing those with 0 to 2 positive experience to those adults who had 5 or 6 or more positive childhood experience, those adults had almost a 25% lower risk of reporting a poor or fair health status, and a 26% lower risk of reporting any psychiatric diagnosis. So exposure to, again, perhaps protective factors, building resilience, results in better health outcomes in this study. This study also looked at the opposite, which is looking at those adverse childhood experiences again, and again, noted the same kind of associations, that with increased adverse childhood experience, there's much greater hazard of developing physical health problems, developing mental health disorders, and a almost 41% greater hazard of developing any physical or mental health disorder in a given year. So conclusions. Findings suggest positive childhood experience play a role in enhancing health resilience by promoting healthy outcomes, while also protecting from poor mental and physical health conditions. Interventions that foster positive parent-child relationships, social engagement in school and neighborhoods, and neighborhood social cohesion may improve health throughout life. Curbing the number of stressful and potentially traumatic events and family challenges occurring before adulthood, preventing ACEs, is critical. And I'm not available for questions, but I'm happy to respond to questions through email.